And welcome to today's Facebook Live with GBMC Healthcare.
Today we're talking about understanding lung cancer, the risk, the treatments, and everything available for you.
Now let's welcome our guest, Dr. Mei Tang, medical oncologist and hematologist at the Sandra and Malcolm Berman Cancer Institute at GBMC.
And remember, we want to hear from you. Anyone watching, please do not hesitate to ask. Join the conversations, type up your questions, and send them our way. Welcome, Dr. Tang.
Nice to be here.
We're glad to have you. Now, what is your role at GBMC?
So as a medical oncologist at GBMC, I take care of patients. That's my main task. And also, I will conduct research with a research team. We collaborate with the multidisciplinary team and work closely with other specialists and with our primary care team.
Okay, so today we're mainly talking about lung cancer, right? And so people want to know, what are their risks? Are there any certain risk factors that can increase somebody's risk?
Yes, so lung cancer, number one risk is aging.
Okay.
So
wow, okay.
In the 1950s, you rarely hear lung cancer because average life expectancy is much shorter.
Okay.
But today, American lives longer. We average life expectancy for men and women is in the mid-80s.
Okay.
So the risk of lung cancer, it does increase with aging. But meanwhile, the smoking and the exposed to certain chemicals or asbestos exposure that increase the lung cancer.
Okay, so with the smoking, is there some way to tell, say you're a smoker, is there something I could look at if I were a smoker myself to say, am I at risk?
Yes, so the amount matters. So how many packs you smoke when you're smoking, and then how many years you smoked.
Okay.
So if we multiply those two together, so for example, if you smoke 1 pack a day and then smoked 30 years, that would make it 30 pack years.
Okay.
Yeah.
Okay.
Got it. Okay, is there a screening test for lung cancer? Like we talk about mammograms for breast cancer, anything that somebody can do to see?
Yes, so for high-risk population, there is a standard the screening test. That's a low-dose CT scan.
Okay.
Low-dose CT scan specifically refer to the low X-ray exposure. So we don't want subject a healthy population to too high a dose of X-ray.
Right.
So it's a low-dose CT scan, which takes 20 minutes.
And this is something that's come out in the last few years, correct?
Yes, in the last 4 years. So it was done as a national clinical trial to look at CT scan, the low-dose CT scan versus chest X-ray. And the low-dose CT scan actually proven to find the early lung cancer and save life.
That's a great development.
Okay,
go ahead.
Nope, you go.
I was just going to say, who should get screened?
Yes, so we are focused on these high-risk groups, right? So the patient, both man and woman, who has more than 30 pack years smoking history, and the age between 55 to 77, and who's in general good health, and who is willing or has means to pay for the screening should get screened. But if someone quit smoking but quit within 15 years, that person should still get the annual CT scan.
Wow, so even if you quit smoking 15 years ago, your risk is still elevated?
Yes, within that 15 years.
Okay, so let's talk about treatment. Let's say that somebody comes to you and they have been diagnosed. Now
right. Yeah, that's actually most of my patients. You know, if they do not have a cancer diagnosis, they do not belong to my clinic. So once they have the diagnosis, lung cancer is a diagnosis by biopsy, by looking under the microscope to make the diagnosis. But once you have the diagnosis of lung cancer, the next question would be what stage, because that matters in terms of the treatment, in terms of the prognosis. The staging workup, including specific procedures like EBUS, EBUS, which is a special ultrasound scope into the airway, and looking to the lymph nodes, looking to the airway structure. In addition to that, there different imagings, we commonly use CT scan, PET-CT scan, or MRI. But lung cancer is no longer just a diagnosis under microscope. Today, we actually group lung cancer into more than 10 subgroups based on the cell surface, protein expression, or the tumor genetics inside of the cancer cells. And based on those information, the treatment is different.
And with all of this development and new treatments, that had to come from somewhere. Tell us a little bit about clinical trials.
Yes, so in the last 10 years, there are great clinical trials focused on immunotherapy in lung cancer or targeted therapy in lung cancer. So-called targeted therapy, my patient always say, is that like the target like we are thinking? Yes, so in the last 50 years, the research in basic science identify the gene mutations, the specific genes that link to specific cancer treatment. So in lung cancer, we have those targets we can identify through the genetic test on the tumor samples, not in the blood. But by doing that, we can identify the target which link to specific treatment options. Most of those options are oral drugs, so easy to handle, easy to take, and the toxicity is less. And if the patient has a specific target, the response rate is higher. It could be 70 to 80% versus 30-40% on the chemotherapy.
Okay,
So
wow.
it's a significant improvement. And the overall survival is better.
That's amazing.
Yeah, I have patient, 80-year-old, barely walking to my clinic when they were diagnosed because of the shortness of breath, weight loss, coughing, cannot sleep well. But once started the treatment, gardening.
Wow.
And spending the beautiful day outdoor.
Okay, so clinical trials really help then. So talking about those, how does somebody get involved in one?
Yes, so we rely on the patients. Clinical trial has specific criteria that patient will be screened and then matched to the suitable clinical trial. We have a dedicated clinical trial team that leading by our 3 experienced nurse, and then we have a full-time clinical trial coordinators will work closely with the research team. It's also the effort from physicians. Yes, so that's the driving force behind it, in the interest, the hope that one day we will find better treatment for our patients.
And that's where we are and why it's so important. So these clinical trials have changed the protocol, correct? Can you tell us a little bit about that?
What do you mean specifically?
Well, the protocol for lung cancer and the treatment of it.
Okay, yeah, so for lung cancer treatment, the immunotherapy through clinical trial have been FDA approved. So now we can offer patient the treatment outside clinical trial. But specifically, if you look at the immunotherapy in early stage lung cancer, we are not clear what would be the rule in the in that space. So there are clinical trials offered to patients that will have the immunotherapy before surgery, or offer the patient after the surgery. So we currently participate in a national clinical trial. It's called the Alchemist trial. In this trial, patient had a surgery for lung cancer will be separated into different groups.
Okay.
And one of the group is actually using the immunotherapy after finish the standard of care to see whether the additional immunotherapy after the standard care can save more life.
So explain to us again, what is immunotherapy specifically and targeted therapy? What does it mean?
Of course. That's a common question in my clinic. So immunotherapy developed in the last 20 years, you know, so it's really come from the basic research you know, the Nobel Prize awarded the basic researchers on the immunotherapy. So specifically for the FDA-approved treatment, the PD-L1, which stands for program-1, which is a molecule can be in the tumor cell or on the immune cell, the T cell. So through this signal, the cancer cell actually can shield themselves from the immune system. So they are escape from the immune system attack, so they can survive. But by giving the immunotherapy, we're actually blocking this communication between the cancer cell to your immune system and wake up your immune system to attack the cancer cell.
Wow, so is this immunotherapy, is that an option for treatment in lung cancer?
Yeah, yes. So currently there are multiple drugs that are FDA approved. Specifically, if we talk about one of the drugs called nivolumab, which is indicated in second-line lung cancer treatment. So comparing to previous standard treatment, only 5% patients live at 4 years with previous treatment. But with immunotherapy, we know that 14% patients will live at 5 years.
Wow, okay.
Sorry, 4 years.
So an increase in the survival rate. What is the typical survival rate for somebody who's diagnosed with lung cancer?
Right, so that depending on the staging.
Okay.
Right, so if someone has stage 4 lung cancer, in the past, that's about 5%. So the prognosis is really poor. But the screening of the lung cancer can definitely prevent the patient diagnosed in the more advanced stage. But for the patient who receive immunotherapy and respond to immunotherapy, the survival rate is higher.
Now we know that November is Lung Cancer Awareness Month, and we're talking about the diagnosis and the survival rates. We were talking a little bit off screen about the difference between men and women. Can you tell us a little bit about that?
Yes, so that's a very interesting topic because apparently there are many studies found that women with same smoking history and age compared to the same age group of men, women actually has a higher risk to get lung cancer. This is not completely confirmed, but many research suggests that. So I would caution all women be careful about the smoking, and then also being the driving force and seek for the screening if you are in that high-risk group. And early diagnosis save life.
Okay. Well, Dr. Tang, we do have a question from social media. We want to check in with Mindy. She said, is immunotherapy a treatment option for other types of cancer?
Yes.
Okay.
So currently immunotherapy is widely approved for metastatic melanoma, or even adjuvant melanoma treatment after surgery, renal cell carcinoma, and the kidney cancer, which is another early indication. And more recently, which you know, in my research field, is the head and neck cancer. The immunotherapy actually is FDA approved for the use as a first line for advanced head and neck cancer.
So what about the emotional support that patients need and their families?
Right.
What type of support do you provide at GBMC for not only the patient but their entire family when they're going through this emotionally?
Yes, so diagnosed with lung cancer is a very stressful period of patient life and for the entire family. So we have a very dedicated oncology support group which will offer emotional support to the patient and their family, including the consultation about daily living, transportation, financial planning, and if patient is really at the end of life, to support someone at the end of life and support their family through that difficult time is the goal of our service.
Right. So talk to us about how lung cancer treatment at GBMC is different from other facilities.
Right. So I'm very proud to present our team. So not too long ago, this is our medical oncology team, including our nurse practitioners, physicians. So in addition to medical oncology team, we also have a dedicated multidisciplinary team, including the thoracic surgeon, Dr. Sullivan, radiation oncologist, leading by Dr. Nooner, and then the interventional pulmonologist, leading by Dr. Matt Woodford. With the support from our radiologist, pathologist, the nutritionist, the survivorship, the case manager. So I can only say I'm very lucky to work with a great group of colleagues.
That sounds like the great place to be.
Right, yeah. How do your patients respond to having that kind of support when they come in?
Yes, so because lung cancer treatment is not going to be done by one specialty.
Right.
Patients do have various questions at a different time of or different phase of their treatment. So we always dedicate one group of physicians or one specialty to lead that part of the treatment. But we constantly talk to each other, and with the support on the EMR, the electronic medical record, we actually can communicate with each other instantly. There's a messenger we can use. There's email, and then also face-to-face contact and discussion is very important. And together we review scan together and decide the treatment plan together.
You're taking care of the entire person as a team. That's so important. And we do have another question from social media. It's from Mindy. She asks, is there a genetic link to lung cancer?
That's a very good question. So currently in lung cancer, there are certain genetic factors that could increase the lung cancer, but majority of patients, we do not have a genetic factor we can identify. So for patients with family history of cancers, especially in the first-degree relatives, meaning parents, siblings, or children, those patients, we highly recommend them to have a hereditary cancer risk assessment. GBMC actually has a team leading by our specialists to evaluate patients or their family for hereditary cancer risks.
Okay, so let's talk about symptoms. What should somebody look for if they are concerned, or what symptoms should be concerning for them, or are there any?
I'm so glad you brought that up, because for a long time people think lung cancer is so sneaky. No one knew till the patient is really, really sick, losing weight, and coughing and have a respiratory distress.
Okay.
But actually symptom matters. So if someone has a chronic cough, not related to any infection, cough more than 2 weeks, that person needs at least a chest X-ray. And if there's any abnormality on chest X-ray, then possibly proceed with a CT scan. And especially remember that high-risk group of patients, if they have in that age group 55 to 77, and also has that 30-pack year smoking history, or quit within 15 years, those are the patients who we highly recommend them to have a screening CT scan.
Very important. So we also have another question coming in from social media. This is from Carol. She says, if I think I need screening, where should I go?
Yes. So a very easy access to that is possibly through your primary care physician, because that's part of the annual visit, annual physical exam, And if there's a smoking history, then that is the patient should have the conversation with the primary, because patient going through the screening also should understand if there is any positive finding that that finding could lead to further diagnostic procedures.
Okay, so we talked about high-risk people as far as people who smoked and age and everything else, right? But what about secondhand smoke? We always talk about the dangers of it.
Right.
Is there anything with lung cancer in secondhand smoke?
There is no specific data in terms of what would be the screening indication for those patients, but there are population studies suggest secondhand smoking do increase patient risk for lung cancer. We just don't have a way to measure it accurately or have a specific way to measure how much, how long, how early the second-hand smoking will increase how much the risk. Right.
Because we've lived through, right now most of the bars in town are smoke-free, but we've lived through times when bartenders and children were exposed to this at such a young age. So there's no data to support it, but it seems to be pushing in that direction.
Yes, that will be very interesting to learn.
So everyone should keep that in the back of their head if they start to feel the symptoms we talked about earlier.
Yes, and feel the symptom, have an early detection.
Okay, and we want to go to social media. We have another question. This one is coming in from Shelly. Is there a connection between vaping and lung cancer?
Yes, that's a great question, because as everybody aware that Maryland just passed a state law regulation that the electric cigarettes, the age that one can purchase electric cigarettes increased to 21, no longer 18. So vaping is a major social issue right now, especially in our younger generation, the middle schooler, the high schooler. And I see it's not only addiction, it's also a risk for airway problems. So far, you possibly are aware that CDC is collecting the cases that a patient end up with lung issues due to vaping. And the case actually increasing every month. So last month, if I remember it correct, it was around 34 cases. You know, we increase the age is one way we can tell the kids don't do it, preventing that. But for the risk of lung cancer, we possibly would not know for a long time.
Okay, I see.
Yeah, because it's you know, the early exposure, but it's also how long the exposure would be. So,
and with the brand new chemicals that are in there, we'll have to figure it out as it comes out.
Yes, definitely.
Well, thank you so much for being with us, Dr. Tang.
Oh, thank you so much for having me.
Yeah, we have all the information there. We've had it up on the screen. How easy are you to contact? People can just go right to gbmc.org?
Yes, that's actually go through that. All specialists or the primary care physicians are listed on the website. And at GBMC Medical Oncology, we try to get the patient in as soon as possible, you know, possibly within 3 days.
Okay.
That's
perfect. 3 days.
Yeah, that's
awesome.
quick. Thank you so much. I know that we enjoyed the conversation. I hope you did as well.
Yes, I do. Thank you. Yeah.
Well, thank you so much for staying with us, and we will talk to GBMC again at a later date.
Sure.